Thank you very much for joining the first free paper session for this conference. I'm Alison Hopkins, and I'm one of the trustees, and we've got four speakers today. So it's a tight ship with free papers, so we've got 8 minutes to present, 2 minutes for questions. So please think about questions so that we've got some interaction here. This is a key aim of the TVS, is to have some discussion. So 8 minutes. So the first presenter is Heather Joy. Thank you very much. Coming from City Healthcare Partnership. You'll find that on abstract number 10, and it's traffic light awareness for pressure ulceration in care home settings. Thank you very much.
Hello, and thank you for letting me speak to you today. My name is Heather Joy. I'm Senior Operations Manager at City Healthcare Partnership, a social enterprise within Hull. In 2012, working with the Hull City Council, the Safeguarding Adults Partnership Board and ourselves, we were able to triangulate data and recognise that we had a problem. Across the whole health community, pressure ulceration was incredibly high, and we started to begin to look at how we could facilitate change and work together to reduce and prevent pressure ulceration. We joined our data together through Datix reports, safeguarding alerts and referrals, and looking at social services activity. The data spoke for itself. 68% of all new pressure ulcers were recorded in residential care settings. Grade 2s, 73% were predominantly in care homes, and again the same similar high numbers for grade 3s and grade 4s. This data does not differentiate between new and old pressure ulceration. So we undertook a review to find out what did it really mean. The review of the data and a deep dive in-depth analysis and through qualitative exploration was undertaken, which showed that many homes had very high prevalence of pressure ulceration, with one home having up to 68% of all residents having a pressure ulcer. A root cause analysis was undertaken that demonstrated that staff turnover was very high, that homes were operating on reduced staffing numbers, access to training was incredibly difficult for staff within care homes, and consistency of care and policy application existed. So the solution was to take our existing partnership and to work together with the residential care staff to look at how we could do something differently. We needed to ensure that there was consistency, collaboration, and a full multi-agency approach. The aims and objectives of our coming together was to ensure that early assessment occurred and that we were able to teach staff to utilise tools to prevent pressure damage. We needed to ensure that there was an overall awareness of skin care and that staff within care homes had a full recognition of the safeguarding agenda, particularly relating to pressure ulcers. So what we did is we undertook several actions, making sure that staff were able to easily assess and identify a pressure ulcer within a care home. We taught preventative strategies and helped staff implement risk assessment tools and introduced a skin bundle to the staff within the homes. We then decided to look at it differently and introduced the traffic light awareness system. We needed to make sure that the system in use within care homes was more meaningful to the appropriate skill level of staff within care homes. Many of those staff were untrained, many of them didn't even have an NVQ. We needed to make it simple, so we were able to take existing tools and categorise them into the 3 following categories. Red, which meant that they needed urgent attention and a clinician was needed immediately. Amber, whereby the carers were able to implement the skin pathway and refer to nursing teams, and green, which meant that the staff within the care home were able to do continuous assessment twice weekly and liaise with MDTs that were put in place. Over 300 staff were trained across Hull. It initially started as a 6-month pilot, but we took it out of pilot within 1 month because the response was overwhelming. We saw a 72% increase in assessment frequency across care homes who had utilised the training. 100% of attendee homes reported that they now had robust reporting in place for mechanisms for pressure ulceration. And over 80% of care homes reported a positive change in implementing the tools that were given to them. And the success of the story, we've seen a 57% reduction in care home reported pressure ulceration. We have named district nurse key workers for all residential care settings across the city, and we have not seen any avoidable grade 3s or grade 4s in care homes that have attended the programme. But we can't just rest on our laurels, so we're now moving forward with the service provision. We are now providing bespoke response to safeguarding alerts. So working as a multi-agency safeguarding hub, we are able to target training where it's needed most. We're able to offer an enhanced service, and we're able to deliver not just in pressure ulceration training anymore, but also the other significant factors that impact upon safeguarding, skin tears and leg ulceration. And we're now able to offer the programme to carers, both informal and unpaid carers, a very forgotten voice within our communities. And thank you.
It was very swift, Helen. Thank you very much. Questions? Rod? Hang on a second. We do have... No. We're being videoed. It's not allowed to shout.
Thank you. Rod Hume, Smith Nephew. How did you ensure that the staff didn't just pick red every time and send it straight back to the district nurse and not take accountability for what was going on? How did you ensure that?
What we did is we put the concept of the name district nurse into every care home. So every care home had a point of contact that they could link with. So even though we may not have had any district nursing patients within that home, they had access to that expertise that they'd never had before. So we were able to identify what the training needs were and to really evaluate what was happening on a case-by-case basis.
Okay, thank you. Has that led to your district nurses calling more or less into the homes?
We saw an initial very high surge of being called into homes, but as we've worked with them, we've actually seen that that's really tailored down, and that mirrored the change in the difference of pressure ulcer reporting. So at first we saw a very high level of grade 2s reported to us, but on the other hand, we've now seen no grade 3s and grade 4s. So the early assessment and identification is working very well, and we're getting to these patients at grade 1 and grade 2, as opposed to grade 3 and grade 4.
And this is a standard way of working now?
This is business as usual.
And you carry on training the staff? Do you carry on training the new staff coming in?
We run training sessions monthly across the city, and we're just rolling those out to all the unpaid and informal carers across Hull as well now. We also work with the multi-agency safeguarding hub, so that through data monitoring we're able to pick up homes where there may be a problem and work together with the safeguarding team to go in and support the staff in those homes.
Okay, thank you. That's probably too many questions, sorry.
Edwin?
Hi, I'm Edwin from Ipswich Hospital. Sorry, I might have missed this part, but would you be kind enough to just explain what were the key indicators for your categorization, as in like red, amber, and green?
Yeah, what we actually did is because we found that in many of the care homes, untrained staff were using a variety of tools which they'd never been trained to use, such as some homes were using Braden, Waterloo. It was very complicated out there, and these were care assistants who had had no formal training. So we decided to break that down, and with each kind of scoring tool out there that different homes used, we categorised into the red, which would be to contact a clinician immediately, so a member of the district nursing team or a community matron, to go out and put an intense package in there for that patient. Amber was for patients that had a medium risk, so we'd look at being able to get the equipment into place for them and to work with them on a joint management plan, but we knew that we had up to 24 hours to go and review that patient. An urgent red case, we made the promise that we would review that patient within 4 hours. And green was business as usual, that we'd carry on with continuous assessment of that patient and support the home through training.
Okay, so does this mean that you use the risk assessment to actually categorize to say who goes in
We've
each section?
worked with each individual home, so we've taken the risk assessment that was used in that home and broken it down and categorised it into just red, amber and green. So whether that's been for Waterloo or Braden, whichever tool's been used out there in each home, none of the homes were ever using the same tools.
Okay, thanks.
Thank you very much,
Thank you.
Heather. That's fantastic. Thank you. Now got Isabel Smith, thank you, who's talking about pain as a predictor for category 2, and you'll find her abstract number 42. Thank you.
Okay, so my name is Isabel Smith and I'm a medical statistician at the CTIU in Leeds University, and I'm presenting the skin sight level results from the pain cohort study on behalf of the Purpose Group. So the objectives of the study were to explore the role of pain as an early predictor of category 2 and above pressure ulcer development, and also to identify which variables are independently predictive of category 2 and above pressure ulcer development. The study was a prospective cohort study of acutely ill hospital and community patients who were deemed to be at high risk of pressure ulcer development. The study comprised a 30-day follow-up period with an a priori sample size of 632 patients. So we recruited a total of 634 patients, but 32 of these were lost to follow-up, so therefore our analysis population consisted of 602 patients. 38% of the population were male, and the age of the population ranged from 21 to 101 years, with a median age of 80. 27% of the population had a pre-existing category 2 or category 2 pressure ulcer, and 70% of the population were bedfast or chairfast. Now, 62% of this population were observed to have skin alterations at baseline, and 29% of those with skin alterations at baseline developed a category 2 pressure ulcer, compared to almost 19% of those who didn't have skin alterations at baseline. There were also 48% of the population who had a category 1 pressure ulcer at baseline, and of these 36% developed a category 2 pressure ulcer, compared to just 15% of those who didn't have a category 1 pressure ulcer at baseline. And there were also 77% of the population who reported pain on a healthy, altered or category 1 pressure ulcer skin site, and of these 28% developed a category 2 pressure ulcer, compared to almost 16% of those who didn't have pain. So we collected baseline and follow-up data on 13 pre-specified skin sites for each patient, and these included the sacrum, the buttocks and the heels. The primary analysis was a patient-level analysis, which means that we looked at whether patients with pressure-related pain were more likely to develop a pressure ulcer. Now, one of the secondary analyses was a skin site level analysis. So this meant that we looked at whether pressure-related pain on a skin site meant that the same skin site was more likely to develop a category 2 pressure ulcer. Now, due to the nature of the data, we needed to adjust for the fact that skin sites within a patient might have a more similar outcome. So for the patient-level analyses, there were 602 patients, and of whom 25% developed a category 2 pressure ulcer. In contrast, the skin site level analyses consisted of 7,483 skin sites, and these are each corresponded to the 602 patients. And of these, just 3% developed a new category 2 or above pressure ulcer. So for the patient level analyses, 9 variables were considered for inclusion in the model. And we considered the same variables for inclusion in the skin site level model, but we needed to specify which of these variables were patient level and which were skin site level. So we defined age, diabetic status, history of prior weight loss, Braden mobility, setting, and analgesic use as patient level variables because these don't change with each skin site. We defined the presence of pain on a healthy, altered or category 1 skin site as a skin site level variable. And similarly, we also defined the presence of skin alterations and the presence of a category 1 pressure ulcer as a skin site level variable. But we needed to combine these into a single skin status variable because no skin site could be assessed as having skin alterations and a Category 1 pressure ulcer. It could only be healthy, altered, or a Category 1 pressure ulcer. So in the final patient-level model, the primary analysis indicated that there was significant evidence that patients with a Category 1 pressure ulcer or skin alterations have increased odds of developing a Category 2 or higher pressure ulcer. And after adjusting for patient skin status, there was marginal evidence that patients with pressure-related pain on an healthy, altered, or Category 1 skin site have increased odds of developing a Category 2 pressure ulcer. Now, for this final skin site level model, after adjusting for the patient variation, there is significant evidence that skin sites assessed as Category 1 or skin alterations have increased odds of developing a Category 2 pressure ulcer at the same skin site. And after adjusting for the patient variation and skin status, there was significant evidence that skin sites with pressure-related pain on a healthy, altered, or Category 1 skin site also have increased odds of developing a Category 2 or above pressure ulcer at the same skin site. So in terms of implications for research, this is the first risk factor study to explore the relationship between localised pain on a pressure area skin site and pressure ulcer development on the same skin site, but replication studies are required. We also recommend that skin site level analyses should be considered in addition to patient level analyses to further explain your data. And in terms of implications for practice, the results of this study suggest that pain reported on normal, altered, or Category 1 pressure ulcer skin sites is a predictor of Category 2 or above pressure ulcer development, and therefore pain assessment and response to pain should be a clinical priority. Thank you.
Another person keeping to time. This is very exciting. Questions? Whilst people are thinking, I have a question. Can you clarify what you mean by skin alterations?
That was defined by the clinical team, and as a non-clinician, right. I'm not very in the best place to define that, but I don't know if there's anybody else from the purpose group who could explain
Anyone
it.
from the purpose group here?
Can, but
if there's any sort of redness, any alteration, anything that you would indicate, so a skin change, so completely intact, healthy skin, any sort of skin change that would indicate.
So maybe blanching, erythema would be a key one. Okay, that's helpful. Thank you. Any other questions? Rod's got another one. Is there any more planned work from your perspective, or is that it?
yeah, no, we've got planned work for the summer. So we also collected data on sort of a time varying perspective. So we're going to look at that in more detail as well to see whether changes over time impact on the pressure ulcer development.
Pain, very important. Thank you very much.
Okay, thank you.
Thank you. The next speaker is actually Michelle Briggs. You can find their paper on Abstract 3. Michelle is talking on pain and pressure ulcer development from a service user's perspective. Thank you.
Thanks. Thank you very much. And thank you for giving me the opportunity. I'm speaking on behalf of Delia, who will be speaking in a little while, and Kay, one of our service users, who has kindly provided one of the stories as part of this presentation. And what I wanted to do was take a little step back and say, where did that cohort study come from? We all think about patient stories as something that adds value to our practice, but actually it's the bedrock of what we do. Medical histories, patient-reported outcomes, everything that we do is a patient story. And what I want you to do is journey with me in where those stories came from. Diane Krasner in 1995 took 42 stories from nurses about how they felt when they cared for people with pressure ulcer pain. And what she talked about was an endless cycle of pain that she was dealing with. In 1999, that Saw in the Bourguignon took 32 people and asked them about their pain, and what they found was that 28 of 32 had pain, only 2 got analgesia. 8 patients asked about what it's like to live with pain, key theme, endless pain. In 2002, another 5 patients in a qualitative study looked at what it was like to live with pain. The key and most prominent factor is pain is the worst aspect of living with a pressure ulcer. In 2003, another study took 20 patients of living with a pressure ulcer. 80% were in constant pain, unrelieved. In 2006, and I have to say, Alison, thank you very much for a seminal paper in this area, because this was the paper that actually looked at, and therefore, what does that pain mean? And there was a sense of, yes, the patients are living in endless pain, which means that they stay still, they have treatment-related pain, and they don't participate in their care as well as they could. And that was supported by another study, qualitative study at that time, to say that there was a communication difficulty and communication breakdowns, and the patients were spending a lot of time talking about their pain, but health professionals weren't listening, and they were mostly looking at the skin. So that was at around about the time, 2007, 2008, is when we, as a purpose group, put our bid in for the programme grant and started to say that we need to be thinking about taking pain seriously. And in 2010, we pulled together all of the qualitative research into a synthesis of qualitative research to say, where are the gaps? And the gaps were that all of the studies so far concentrated on grade 2 to grade 4 pressure ulcers, that we didn't know what the impact of a grade 1 pressure ulcer is. We didn't know if it was painful. What we did know was that grade 2, 3 and 4 are constantly painful, that people have poor pain relief, but we didn't know whether pain was an early indicator of pressure area care. As Isabel so eloquently described, we know now that it is. But we did know that patient education was poor, our participation with service users was poor, and that patients were doing their best to get their message across, and we were ignoring them. So we presented that to the Person Pressure Ulcer Service User Network to ask about their opinion about how we should disseminate the research. And they came up with 3 stories as a result of presenting that work, and Delia presented that work on our behalf, which I'm very grateful for. And what I'd like to do with the last time that we have available is to just read some of those stories to say, have we moved on in our pressure ulcer management? So, Kay's story. Are you happy for me to read this? Kay, I've had a pressure ulcer approximately for 2.5 years. For much of that time, I've been advised to spend most of my day in bed to keep the pressure off my ulcer. Recently, I made the decision to have surgery to help heal the pressure ulcer and was told it's now okay to spend a little more time in my wheelchair while I wait for the surgery. Unfortunately, when I sit in my wheelchair without painkillers, I'm in agony. I would describe the pain as a cross between burning and stinging. It's impossible to know how much longer I will have the pressure ulcer for. This somehow makes the pain harder to deal with, as it's difficult for me to visualize a time when I will be without it. The pain has quite a big impact on my mood and my relationships with other people. Painkillers like paracetamol don't help. I've been given Tramadol, but I struggle to function when taking it. Medication makes me feel I'm drifting in and out of consciousness, and I worry that I'm not speaking clearly. I'm really pleased when I was told I didn't need as much bed rest. I felt I had my life back. Unfortunately, it hasn't been like that, because every time I go out, I have to make the decision between a great deal of pain or dealing with the difficult side effects of painkillers. That was Kay's story.
I'm going to read this next story on behalf of Carol. Carol says, I often suffer with pain from pressure. I have MS. I have pain from that all over my body at times. I can't walk far. I use a walking stick and my balance is poor. I also suffer very badly with fatigue. I find sitting very tiring. During the day, I often have to lie down for long periods of time and sometimes find it difficult to move. I tend to lie on my side, as this is the most comfortable, and when I have enough energy to read or watch TV, it's easier for me to do this when on my side. I tend to get lots of pain on my left-hand side by my hips and at the top of my leg, as that's the side that I lie on more often downstairs. When I go to bed, I try to lie on my right-hand side so that I alternate it a bit. My bed upstairs is much more comfortable than the hard day bed downstairs, which is why I think I get more pain when I lay downstairs. I'm concerned that this pain may lead to me developing pressure ulcers. My mum, who also had MS, developed one, so I know about the risks. She used to sit for long periods on the floor, sitting against the sofa or lie in one position because she was unable to move or turn herself. We don't know how much pain she was in because she couldn't communicate by the end. I don't think that I've ever been warned about the risks of developing a pressure ulcer by my healthcare professionals, despite me saying that I sometimes can't move and have to lie down all day. I think this is because I look reasonably well when I can get out to see people, and I cancel things if I'm unable to get out. So people often assume that I'm fine and don't think about pressure ulcers for me. Also, people often think that the pain is caused by the MS itself, and so don't look any further or consider that it could be due to other things.
And the final story is Claire's story. My husband Graham had stomach cancer and spent 4 days in hospital prior to his last 6 weeks at home, cared for by me. He was so thin that they arranged soon after he came home for an inflatable seat cushion and a mattress to be delivered by the district nurse, who used a pump to blow them up. During the early part of the 6 weeks before the end of Graham's life, a district nurse found a small red patch on his heel. The nurse said that this could be the start of a pressure ulcer and that it was pretty much inevitable that he would get more. At this point, he was unable to move without help. At this time, he was still in a normal double bed and we wanted to remain together. The inflatable mattress did not stop the discomfort, and Graham felt that when he had been lying in one position for too long, I would help him to turn over and become more comfortable. Although he was offered a lot of very strong pain medication, Graham chose smaller doses that he could remain alert for longer and keep control over his care. This meant that he was able to let me know when he was in pain, and as time went on, he needed more help, and I was turning him every 2 to 3 hours, day and night, and he was unable to do much to help. Towards the end, his voice was not strong enough to wake me, so he had to tap on the mattress and let me know he needed moving. I checked Graham's skin regularly and recorded any red marks. His skin never broke down. I believe that reacting to Graham's pain and turning him not only helped him make him more comfortable, but stopped pressure ulcers developing. It was hard turning somebody so much taller than me in a double bed, but I valued the physical contact between us. The reason that we've presented this paper today is to show you that patient stories matter and that patient stories were at the beginning of that cohort study, understanding the patient experience and helping people tell their stories. That then fed into the qualitative evidence synthesis, which helped design the study that Isabel has presented. And without our telling stories, valuing the qualitative stories and embedding that qualitative work into the cohort study, we wouldn't have been able to bear the fruit of that study in the same way. Recommendations from Pearson, their plea is that there needs to be a clear strategy for managing pressure ulcer pain. We know and we've known for years that this is a constant, debilitating, painful condition. Pain management plans should include alternatives to those who don't want pain medication. There are many alternatives. Please refer your patients with pressure ulcers to pain teams. They can do a lot to make a difference. And there needs to be an integrated recognition and management into self-care advice so that the pressure ulcer risk assessment for the last 50 years has been at the skin site level. And I think that I can say that solidly because actually go back and look at every risk assessment scale and see if pain is there. I'd like to thank our sponsors. Thank you very much.
Thank you very much, Michelle and Kay and Delia. Any questions to Michelle? Thank you. Heidi.
Heidi Sandoz, lead nurse for wound care with Accelerate CIC in Tower Hamlets and also vice chair for the TVS. I've got quite an interest in the unavoidable status of pressure ulcers. And we've published on that, but it's interesting that often end-of-life pressure ulcers are seen as unavoidable. And you've just demonstrated quite a touching story. I don't know if anybody else was feeling emotional by that story. where the lady has spent the last few weeks of her husband's life turning him religiously 2 hourly. Now, if he'd been in hospital, he possibly wouldn't have got that level of care, and he may have developed a pressure ulcer, which may then have been deemed to be unavoidable, because our resources wouldn't allow us to turn them more often than that. So I think it's quite interesting. In a way, she's demonstrated that actually that could be an unavoidable pressure ulcer, because she managed to avoid him developing one. So I think that adds to that debate a little bit more than we...
And I think that we need to be really honest about what we mean by unavoidable, because we're within the existing resources, it's unavoidable. And it's the same way that people have a disability, and usually it's the surroundings and the context that they're in that disables them. Disability doesn't mean inability. Pressure ulcers that are unavoidable don't actually mean unavoidable. It means, are you prepared to put the resources in and work in partnership with people to avoid them? That's my opinion.
Yes. Rod?
Thanks, Michelle. Very good talk, that. Thank you. Your comment there about referring to pain management teams seemed to imply to me that people haven't been doing this in the past, as there might be a barrier or they don't exist. And you said that this pain has been going on for years. So what are those barriers, and what's been done to break down those barriers? Because it should be an automatic thing for staff to be able to refer to it, surely.
You're absolutely right. One of those barriers is, I think, that there's a... if we go back to Krasner's work, she talked about 42 stories of nurses of how you deal with people with pressure ulcer pain, and there were 3 models that were in play there. Those who nursed expertly, they recognised the pain, they responded to the pain, and they appropriately got clinicians in to help with the pain. Those nurses who denied the pain, failed to hear the cries, and did not attend to the pain, and a group of nurses who were frustrated and sat and spent time with the person in pain, but did not expertly deal with the pain. I think we're probably still there, and the majority of people are either in group 2 and 3 and not in the expertly connecting with what we know about pain management. If you have back pain, this wouldn't happen. I'm part of a pain team, I'm a pain specialist. We are inundated with people who have back pain, cancer pain, every other sort of pain. I rarely see people with complex wound pain until they get to the palliative care stage of life and they're in a hospice. But certainly earlier on, I don't see them. I don't know why they're not referring.
Is it awareness, communication, education? Are those the roots of it?
Well, I don't know if awareness has been raised for the last 15 years. That's what that slide was about, is that I think that most people would recognise that pressure ulcers are painful. So I don't think it's awareness. So I'm not sure why, other than to say it's actually for me, I think the difficulty is that we focus very much on what we can assess, so we focus very much on what we can see and prove, rather than listening to patients and not acting on what we hear and believe. So that would be my answer.
And maybe the issue of time.
Well, and that's the other issue, is that it's quick to do a skin assessment, and that might only take 2 minutes. To listen to a patient's story takes longer, and also it's sometimes much more difficult to do justice to patient stories and really pay attention to what the issue is. So that does take more time, yeah.
Excuse me, if I could just, sorry.
Yes, Kay, yeah.
This is a statement really rather than a question. Oh, you're all right. On the show. It was more of a statement, but because pressure ulcer awareness, and like you just said, well, if they are unavoidable, like Claire's story, she turned her husband, so would that have happened in hospital? Whereas I got to this age I've never had a pressure ulcer before, because I've got a high awareness of pressure ulcers. What mine was, it was an injury, and then pressure exacerbated the injury. Do you know what I mean?
Yeah.
It's not a pressure ulcer in its traditional sense. So I do think that if you're in your own setting, this is backwards from her story.
Yeah, no, it's really helpful.
There are quite a big difference. think the closest I've ever got to blunt it is when I feel staying in hospital, because I'm not in control of my own turning and see, I turn myself on, I'm not in control of my own routine and I've got to be on the bed, you know what I mean?
Yeah, no, and that's really helpful, Kay, and it reminds me to say that actually what we don't do well is add pain into patient education. So people who have good awareness will be able to respond themselves and report themselves. And what the systematic review that Claudia and the team did showed very clearly that patients were talking a lot about pain, but it wasn't being responded to from a health professional point of view, so they assumed therefore it wasn't important because people were paying attention to other things, and therefore you don't say something for very often until you stop saying it because you think it's not important.
Again, on that as well, what you find is the majority of people most people who are in the at-risk category are usually in chronic pain anyway, so it's usually passed off as it's your condition. Not passed off, I don't mean that.
Yeah, no, but
I just mean usually the explanation for that is usually your condition, not.
Yeah, like Carol's story about her MS. Yeah.
I mean, you could get a pressure ulcer pain, but it's not. It gets passed off as MS pain in the beginning.
Thank you very much indeed. We need to move on.
Yeah,
thank you.
Thank you. No, thank you.
Final, Charlotte Johnson. You'll find Charlotte and her colleagues' abstract in abstract 43. And this team are talking about Stop the Pressure. And a group of students, welcome. Thank you.
Thank you for coming to listen to us. So we've come here today to talk about a Siskin tool that we sort of redesigned and brought out a new version that was directed at students. We were asked to do this by Dr. Ruth May, who's the Chief Nurse, NHS England, Midlands and East region. And it was a way for us to sort of emphasise to students how they can connect theory to practice, to encourage them to look at the wider picture rather than a set of actions that they can be doing. We wanted to demonstrate the importance of pressure ulcer prevention to them, how important it is throughout all areas of their practice, even as students, and their responsibility that they have in promoting the issue and in doing so. We thought that hopefully it would take it from a set of actions that they could just do to something that they're thinking about, and importantly, helping them feel like they're part of the solution towards preventing pressure ulcers. So we formed a little working group. There was a few more of us than there are here today, and we batted out ideas between us about what we thought as students was important to students and how we could get them to think and engage with the issue of preventing pressure ulcers and Stop the Pressure campaign and the Siskin tool a bit further. So without further ado, I'm going to ask my colleagues to talk about what we came up with and why.
So S, we felt, stood for shadow. As students, we recognise the value and experience of our professional peers. Utilising that experience is valuable for our own professional development. We felt spending time working alongside tissue viability nurses is vital to gaining first-hand insight. Our NMC Code of Conduct stipulates we must ensure advice we give is evidence-based if we are suggesting healthcare products or services.
We as students thought that the second S would be best represented by signs and symptoms. We as healthcare professionals need to know the signs and symptoms of a pressure ulcer. Not only do we need to be able to recognise the early signs and symptoms, but we need to be able to act fast and prevent further damage. We need to be able to form a structured care plan and ensure that appropriate action is carried out, but that it is filtered down to all levels. By doing this, we can strive to improve patient care and communication and improve the therapeutic nurse-patient relationship. We are all responsible for giving our patients the best possible care we can. We need to know the signs and symptoms and be able to act fast. Research suggests that majority of pressure ulcers are preventable with early recognition and a good standard of care.
For the K, we decided that knowledge would be the most appropriate word. We chose knowledge as we believe it's important to keep our education up to date as students. It's also important to recognise that learning doesn't stop just as we graduate and get our qualification and registration. It actually continues throughout our entire career. You never stop learning as a nurse. It's important to be able to challenge yourself and the healthcare professionals around you to develop your own learning, also to improve patient-centred care. We also believe that it's important to educate our patients and also the carers and families around them. By doing this, we will hopefully continue to improve the patient care and make headway in this much-needed area. This will also help reduce the number of patients with pressure ulcers. As you can see at the bottom from the NMC Code of Conduct, you must keep your knowledge and skills up to date throughout your entire working life.
And then moving on to I, so we decided as students that we wanted that to stand for, well, we had two things, innovate and implement. We recognise that as students sometimes we are learning from all of our peers, all of the nurses and all of the experts around us, but sometimes we're the ones that have just learnt the newest piece of evidence base. And although we may not have the expert knowledge to be able to implement that straight away, it's certainly something that when we go to a different ward setting, who may not have heard of it, it's something that we could perhaps promote or mention and talk about and raise awareness around. So we thought that just because we're students doesn't mean that we don't have a part in raising awareness around new evidence bases and around best practice. And we just thought it was really important that students had the attitude of be the change you want to see. No one's suggesting that we're experts and we've got all the answers, but there's certainly no reason why we shouldn't be a part of that. And again, linking back to the NMC Code of Conduct, point 22 says you must work with colleagues to monitor the quality of your work and maintain the safety of those in your care. And sometimes that may come from the latest piece of research that you've read as part of your university studies, or a previous ward that you've been on, where you can then take that learning and share that going forwards.
We felt that N should stand for Nursing and Midwifery Council. The NMC conduct states that we as students are accountable for all our actions and the knowledge we have.
We believe that this is equally important for all healthcare professionals, regardless of level, branch or speciality. Under the NMC Code, we exist to safeguard the health and well-being of the public. We must protect them, and we believe that this should occur from the first day of training. Students must be made aware of these.
I'd like to thank you all for listening to our presentation, and if you've got any questions, please feel free to ask.
Thank you very much to the team. Any questions?
Heidi Sandoz, Vice Chair for the TVS. Interested to know, as students, with the knowledge that you've picked up through the work with the NHS Midlands and East, when you've gone into clinical practice areas and perhaps found yourselves dealing with situations that you've wanted to change, and I'm expecting that you voiced that, have you experienced hostility or willingness to work with you? And have you handled that if it's been the former?
So I suppose that we've all got different experiences. When we held the Stop the Pressure conference back in October, we got quite a lot of testimonials from students afterwards who have had good experiences soon, and I think it's because they felt a bit more part of the responsibility. They could share that responsibility, so they felt that actually they had a place in being able to speak up, whereas beforehand some of them have felt that they hadn't had that they didn't have a part in preventing pressure ulcers. We were just being told to do what we were being told to do. I've certainly, in my own experience, and I'm cautious of what I say, and I have to be because I'm speaking to a wide audience and it's quite obvious which trust I come from. So I've had bad experiences with patients who have been identified at very high risk, and staff have refused to order mattresses, cushions and things like that in place because of the setting that we were in. That didn't go very well for me, and this was before the conference, and I think that's what in turn spurred us on to develop something like this and to get students involved. Since then, I've had really, really positive really, really positive feedback and really positive experiences of sort of, even, you know, as a student, we're quite blessed because we can act a bit stupid sometimes. We can sort of say, oh, but I read it should be done like this. I mean, tell me what you think. And then actually it makes whoever we're speaking to, it makes them think about what they've just said to us. And so since October, had really, really good experiences. Before that, not so great. I don't know if any of these guys have got their own experience, but quite a lot of students have been coming back to us saying, oh, I managed to do this the other day and I could do that and I spotted this and I did that. And so, yeah, it's been we've had some really, really positive feedback since.
Well, it's good, doesn't it? Because it's helped you learn how to handle that as well, and how to better approach wanting to introduce change. You gave a really good example by saying, you know, you act a bit dumb, but actually, I don't know if there's any medics in the room, but sometimes that's the way we do it with doctors as well. So. Well done to all of you.
Thank you.
Okay. Rod, be consistent.
I better do, isn't I? Yeah. So what happens now? Will this be part of the curriculum at Lincoln, or will it be curriculum elsewhere, or does it rely on local champions to make sure it happens? Which, okay, let's see what happens.
It's a mix of all, really. So we've it's gone now. The little green Siskin cards that everyone's got, I'm sure you've all seen them. Well, we had those made for all of our students, and I think there's a big surplus of them somewhere. I've been told they're going out to all student placements throughout the country. Jane Cummins saw it and said it was great, and she wanted to see it everywhere. So there's that. The idea of the day of educating, motivating and inspiring students to get involved in pressure ulcer prevention has spread throughout the country as well. We've got 13 other universities lined up to hold their own. But also, you know, at the end of the day, we're being realistic. We're not going to get everyone enthused, and, you know, we'd like to, but being realistic, it's probably not going to happen for everyone. So I think even if we just manage to create a few little people that champion pressure ulcer prevention amongst the student cohort in their area, then that's better than nothing, and it certainly inspires other people. So.
And was your education stroke awareness of pressure ulcers, did that happen before the conference, or hasn't appeared yet in your academic curriculum?
We had an hour. An hour, and about 20 minutes of that was on prevention, if that. Some of you will know our local trust TVN, and he was great. He really wanted to get into the university, but it depended on his timetable and on ours. And obviously it's not the university's fault either, might I add, because they've got so many things they have to fit into our timetables. Something has to give, and I think they hoped that we would go into practice and learn this, but actually we've got an issue with pressure ulcers. So some areas do it really well, we get really, really good education. Some areas not so well. We don't get very good information and education, and it's not a priority. So then you get a whole new load of student nurses graduating for who it isn't a priority until maybe they have a bad experience. I was lucky, I had the best tissue viability nurse, present company accepted, who was a community nurse, tissue viability link, and she was fantastic. She taught me everything she knew. And she really, really inspired me, but not everyone had that. And I was going back into university and people were going, Siskin? What's Siskin? Or pressure ulcers? Not interested. And I didn't think that was good enough. So we did something about it.
Thank you.
Thank you, very good.
Thank you very much indeed. So we've had some fantastically inspiring talks, 4 really good talks. Thank you. Moving patient stories, good questions that we need to answer, and then inspired to be, what was the phrase? Be the change you want to see? Excellent. We'll end on that note. Thank you very much indeed.